Hello, everyone. I'm Bob Alico, president of SCAD Research, Inc., and I'm just going to present a couple things to you. We've all had people commenting on the wine, so I think I'm going to go to that first, and then we'll go to the second thing I need to do. The wine that we have here is from an agreement the SCAD Research, Inc. board made with a wine company called Summerland Wine. And what they're going to do is for every bottle of wine that they sell under their Cloud Valley label, and I'll show you this, see if we can, what I can get you to see. I don't know. Anyway, anything under the Cloud Valley label, they have like four different labels, maybe 5. Anything in Cloud Valley, SCAD Research, Inc. will get a donation from Summerland Wines. And if you look on the back of the bottle, you'll be able, if you're questioning when you're at the store, you're going to see, let's see if I can do it. Okay. So you see right here, SCAD Research, Inc. logo. And it also has just a tiny saying on the back label, and it says, a portion of the proceeds will go to research SCAD spontaneous coronary artery dissection, the #1 cause of heart attacks in women under 50. For more information, visit scadresearch.org. And then we have all the other agreements with them, and they'll be sending us the proceeds. So anyway, every single bottle, every case that's sold, donations made to us. You just got to, only thing you have to remember is you go to our website, go to scadresearch.org. I'm just going to give you a quick 1, 2, 3 so you can find it easy. Scadresearch.org. When you get on the website, go to SCAD Research, then scroll down and you'll see sponsors. When you hit sponsors, it'll go over to the right and it says corporate sponsors. So click on corporate sponsors. Then you'll see a logo. It says Summerland Wines. Click on that. It'll take you to their website. And then you'll see their different brands. And as you go through it, just make sure you go to Cloud Valley. And anything you read about it, and my suggestion is one of 2 things. You can either order it online, and they'll have all the instructions on how to do that. Secondly, a good idea was brought to me by someone, and they said, if you go to where you normally buy your wine, and you ask the person, say, look, do you carry Cloud Valley wines? That's the best way to get that wine to be put into the store where you're at, because Summerland Wines has salespeople trying to get it to different locations. If we ask for it, those people will put the wine into the store. So it's a fundraiser. It was supposed to start August 1st, but it started in October because of the supply backup. It's just now starting to get into the stores. So that's one thing. The second thing is, well, we're all talking about anniversaries of their SCAD and everything. Well, we have a SCAD survivor that came to us and said that they were so very, when they had their SCAD, she had her SCAD heart attack, it was like 5 years ago. She said, Bob, from the best I could remember, there was about 1,000, this is rough, about 1,000 people in the survivors group. She says, now that I look at it, there's over 5,000. So what she came to us and said, I want to make a matching grant challenge. She said if she would do this from now until exactly, I don't know, I can't remember the date, it's this 24 hours from now or 36 hours from now, for every $1 people donate to to SCAD Research Inc., she will do a 2-for-1 match up to $2,500. Then after that 36 hours is over, until November 7th, every dollar we bring in, she'll match it up to $7,500. So in reality, if we bring in $7,500 between now and November 7th, we'll end up with $15,000. So it's a great challenge. You can find out about it. I think Jan sent out Facebook. I think we have it on the website, if I'm not mistaken. It basically is a very simple thing, but she said she was so encouraged by seeing how many people are in the Facebook group. It made her want to do something, knowing that we had to cancel a couple of years because of the pandemic. And so that's what her offer is to us. Those first 36 hours, 2-for-1. Every dollar you donate, she'll do 2, up to $2,500. Then after that, every dollar you donate, she'll match that dollar to $7,500. So it's a win-win for us. Thank you.
Okay, Carol, it's now Carol. We're going to have Carol talk. Thank you, Carol.
I am here to introduce Dr. Hayes. So I'm really excited I get to introduce Dr. Hayes. For any of you that don't know, she is the team leader of Mayo Clinic's SCAD Research program. And you will be hearing from her shortly. We also have a number of other team members as tonight's presentation, and Dr. Hayes will be introducing them. So for all of these people, team members, the ones who are here tonight, the ones who weren't able to be here tonight, we are so appreciative of everything they do for the SCAD community, and we are especially thankful this year that they've given up their Saturday evenings to join us. Okay, so back to Dr. Hayes. Just something I want to talk about for a few minutes. Recently, Forbes, for any of you who haven't heard this, recently Forbes announced their first ever vision list, that's what they call it, to highlight 50 female visionaries over 50 who are shaping the future of technology, science, and art. And we are so excited to let you know that Dr. Hayes was one of 50 who was chosen. And in part because of the research on SCAD, her research on SCAD. So yeah, big hand for Dr. Hayes, and congratulations, and thank you so much.
Thank you, Carol. And so, yes, you've outed me. I am, in fact, over age 50. So just, it's out there now. It is a pleasure to give up a Saturday night to be with all of you, because this is so important to me and to the team that joins me tonight. I thought I would just, I'll start by introducing the team and then telling you a bit about what we're going to do tonight. So I'm joined by Dr. Patty Best. Dr. Best is an interventional cardiologist colleague here. She is one of the two individuals who, when we get the angiograms from you as part of the research, is the one who reads them and reads them blind. So she is looking at the angiogram to see if this is confirming SCAD. She has a busy clinical practice caring for SCAD patients and is a very integral part of our research. Dr. Rekha Mankad is also with us tonight, she is my boss in the clinical realm as she directs the Women's Heart Clinic at Mayo Clinic, and has been very active in seeing SCAD patients as well as supporting the practice as we move forward and helping coordinate and provide support. We have we have Kari Dessner, who's our nurse practitioner within the Women's Heart Clinic, who many of you may see a note from her if you've seen recently. She is here because she is also a very integral part of our clinical practice, less involved in the research. And so you'll hear from her during the conversation because she knows a lot about SCAD. And then we also have a bit of a surprise guest. Dr. Tweet thought she'd be tied up, and she's going to give us about an hour. So Dr. Marysia Tweet, who is my other partner in crime in terms of SCAD research, who started with me doing this back in 2010 when she was still a medicine resident. So she is really the future of SCAD research at Mayo Clinic. And Dr. Galati, I have not seen if he is for sure on. If he is, I'd love for him to unmute and say, but otherwise I'm hoping he will pop on because we expected him. So Dr. Galati is an interventional cardiologist who many of you have seen him in some of the videos that we've produced. And he is also one of those who both sees SCAD patients, who reads angiograms, and has been a big participant with his expertise in terms of SCAD and interventional cardiology. So the other person who is, a couple people who aren't here I want to acknowledge. One is Dr. Tim Olson. Dr. Olson has been, who despite being a pediatric cardiologist, has been the heart and soul of our genetics of SCAD. He has created and maintained the largest DNA biobank in the world of SCAD patients and their parents. Dr. Olson retired this summer and is not with us. He recorded a video for you, which we're not going to be able to show tonight, but we'll put online, and perhaps Nick can actually attach it to the video when we share it. And then the other person who is sorry that she cannot be here is some that many of you who are part of the research, and I realize not all of you are, is our study coordinator, Sue Milbrandt. Sue joined us last year and has been amazing in both her compassion and organization in really helping us. And she said to say hello to everyone. She had a previous commitment. She says, our SCAD registry is growing thanks to your commitment and perseverance. If anyone has questions about the SCAD registry study, or if you're waiting to hear from us and it's been a while, like we haven't gotten back to you, please send a reminder email asking what the delay is. Sue loves hearing from you and doesn't mind a reminder email every once in a while. And the email address is mayoscad, all one word, @mayo.edu. So she says, enjoy the presentation. So we are here for you. So I saw one comment that said we shouldn't have to self-pay for research. I would say that we would love to get more NIH and American Heart Association and other grants, and we have gotten some of those. But honestly, the beginning of research for most conditions starts with grateful patients or with people who are affected or family members who are affected. And I think it is this wellspring of people who, your friends, your families, who have helped provide over $1 million to propel this research, is why we are here where we are. And I just want to let you all know that we are committed to continue to try to obtain funds. I will say that Dr. Tweet last year successfully competed for NIH funding for SCAD research that will be done. She can tell you a little bit about it during the discussion part, where she's going to be working with one of our colleagues, Dr. Mike Joyner. So I think it takes a village, and it is sort of that catch-22. If we're going to get external funds, we have to show that we can do the work, that we're capable of it, and that we have some success and that we're on the right track. So every little bit that you all have shared with us, including, even if it's not money, volunteering as a participant in the research. And for those of you who are SCAD survivors who are not part of the research yet, please let us know. You again, Sue Milbrandt is the one to do, mayoscad@mayo.edu. So tonight's program is going to be a little bit different than what we've done in the past, where we've done a lecture or we've each talked about something and given a little part of it. What we thought we would do is share a brief video. It's 15 minutes. It is a video that I created at the beginning of this year for other healthcare providers. So it is a SCAD 101. Those of you who registered for the event should have gotten a copy of a sort of a glossary to explain the acronyms that we're using in it. Remember, and I'm going to say this several times, if you don't get it, if there's something you don't understand, don't worry about it. We will type it in the chat. We'll talk about it afterwards. This is a video that is created for healthcare providers, internists, family practitioners, and cardiologists. Anybody else? So you're going to watch it tonight, take what you can from it, ask us questions afterwards, and then share it with your healthcare providers. It is available on the Mayo Clinic cardiovascular CME site, and it's free of charge for anybody to watch. So again, it's only 15 minutes of your doctor's or your nurse's time. So I'm gonna start with, let's make sure I don't have anything else. Okay, I am going to tee up the video. And we're going to play it, and feel free to put things in the chat. We'll be making that, and then we're going to bring our Mayo panel back for a few minutes at the end to answer your questions, either about the video or other questions that you have about the research, and we'll share a bit about that. All right, thank you, and I am going to share my screen.
Hello. I'm Dr. Sharonne Hayes, cardiologist at Mayo Clinic, founder of the Women's Heart Clinic, and director of the Spontaneous Coronary Artery Dissection Clinic. Today I'm going to talk about spontaneous coronary artery dissection, what it is, how it's different from atherosclerosis, and what we should be thinking about as we care for these patients. So what is SCAD? SCAD isn't atherosclerosis. So it is a dissection or a separation of the intima and media of the coronary artery, often not associated with any or only very little atherosclerosis. It presents as either an intimal flap, as you can see on the far right, or an intramural hematoma in about 80% of the cases. As you can see, if we were to do a luminogram, as in a coronary angiogram, the intramural hematoma can look very similar to atherosclerosis. You may say, why are we talking about SCAD so much more in the past decade? Well, in part because we were taught prior to about 2010 that the way to diagnose SCAD was with that intimal tear only. We now know that about 80% of SCADs present with an intramural hematoma, so we were missing 80% of them. What else is different? Well, SCAD is different from atherosclerosis in its demographics. The average age is considerably younger, ages 42 to 52, 90% women. About 5 to 15% of women are peripartum. Now, we used to think it was higher, but that's probably because we were missing many of the non-peripartum SCADs. Cardiovascular risk factors are uncommon and much lower than those individuals who have atherosclerosis, but they're not absent. Actually, hypertension is present at about the same rate it is in the population. It's also not rare. As I alluded to, we were missing it. It represents probably about 1 to 4% of all heart attacks. It's the number one cause of pregnancy-associated myocardial infarction and the number one cause of MI in women under 40 and perhaps under 50, where it makes up over 7% of myocardial infarction. It also isn't benign. You know, when we first started looking at this, patients were being either being told, go on and live your life, this is no big deal, or alternatively, you're lucky to be alive because most people die. And that part of that was because most of the literature up until about 10 or 15 years ago was in the pathology literature. But about 50% of SCADs present as STEMI, about 15% as in cardiac arrest, and about a quarter of individuals have multivessel SCAD at presentation. SCAD can recur. It isn't just a lightning strike that will never happen again, sadly, at about 2 to 3% per year. We unfortunately do not have a lot of risk stratification options. We can't tell individuals, oh, you're at high risk or particularly low risk, haven't found those risk factors yet. We know that traditional treatments for acute coronary syndrome, and in particular PCI, may cause harm. The success rates are far lower, and the complication rates, particularly related to abrupt vessel closure and extension of the dissection, are much higher. And there is long-term some significant morbidity and major adverse cardiac events. The other important thing, unlike atherosclerosis, is it often heals without treatment or intervention, which is why we sort of focus on what we can do from a conservative management standpoint, because many of these individuals will do well. There are rare familial cases, but we know that there is no single SCAD gene, only some people predisposed, and no secondary prevention strategy yet, other than good blood pressure control and, in fact, trying to achieve normal blood pressure. So where does SCAD fit in? We sort of look at this as there are some associated conditions, and those include pregnancy, as we've mentioned. We'll talk more about associated arteriopathies like fibromuscular dysplasia, susceptibility genes, so not a single gene, but just like atherosclerosis, genes that may make an individual more susceptible to dissection. Inherited arteriopathies like vascular Ehlers-Danlos, and then other factors. It does appear that there may be a higher rate of hypertension, preeclampsia, infertility, and migraines in patients who have SCAD, but we don't understand the mechanism. So we take those associated conditions and perhaps a trigger or perfect storm, such as pregnancy, sex hormones, intense exertion or Valsalva, or intense emotional stress, that may contribute. About 25% of individuals have a recognizable trigger of either intense exertion or emotional stress. So what do we need to look for? First of all, it's important to remember that SCAD presents very similar to other types of heart attack, chest pain, shortness of breath, VF, all of those things. The challenge is the index of suspicion is often quite low because these are young, healthy-looking individuals. So we need to maintain that index of suspicion, get the troponin and ECG. And then the way we actually make the diagnosis is with coronary angiography. We recommend careful coronary angiography after intracoronary nitrates to make sure we are not fooled by spasm. We're looking for intramural hematoma, that flap or tear, but sometimes things are indeterminate. So if we're not sure at the time of acute diagnosis, sometimes optical coherence tomography or intravascular ultrasound can be helpful if it's safe and feasible, patient stable, but at a risk of propagating the hematoma. Coronary CT angiogram afterwards, particularly if there's a proximal coronary involved, can help differentiate and exclude calcium and atherosclerosis. Sometimes if it were well after the fact, we're looking retrospectively. Imaging for arteriopathy could be confirmatory, or repeating coronary angiography at 4 to 8 weeks, recognizing that that may raise the risk of iatrogenic harm. I think it's also important, some of you who are familiar with SCAD may be familiar with the type 1, type 2, type 3, and even type 4. Those are angiographic appearance types, not physiology. And so I think it's more helpful and more related to prognosis to say either intimal tear, so that's when we see a flap, or type 2 and type 3 are both types of intramural hematoma, just differences in size. And it's important because those actually have prognostic implications. So once we've made that diagnosis, remembering the primacy of conservative management. So this algorithm, which comes from the American Heart Association scientific statement on SCAD, is looking at if the patient is clinically stable, they don't have high-risk anatomy, which is left main or two proximal severe dissections, then conservative management is desired, but we monitor the patient for 3 to 5 days because of early extension of the hematoma. In those individuals with high-risk anatomy but are stable, we can still watch them, but we should also consider CABG and not doing PCI, which would be very complex. If they have active ongoing ischemia or hemodynamically unstable, sometimes that rock in a hard place and we must do PCI, but urgent bypass surgery certainly is an option. And remember that the major goal is restoring flow, and it's not to make that vessel look pretty or perfect. It may have some ongoing healing. For early after, we watch for symptoms. Some of these individuals, as you see in the diagram, if they have intramural hematoma, it may expand, particularly if anticoagulants are used, and it can lead to occlusion. If it decompresses by forming a tear, they often do better. Managing symptoms, often with vasodilators. and extending that hospitalization. We generally use beta blockers early, at least for a year and possibly longer, and aspirin. I alluded to the fact that most of these patients have a diagnosable extracoronary arteriopathy when we look for it. Most commonly, it is fibromuscular dysplasia, an abnormality of the medial layer, the muscle layer of the arteries, that often presents as a string of beads, as you see in the center, the angiogram related to the femoral angiogram. Can also have other dissections and aneurysms. And obviously, sometimes there may be aneurysms or dissections either in locations or of a size that need monitoring. So we recommend, and it is recommended, that individuals after a SCAD have a one-time imaging, preferably with CT angiography, but also MRA is helpful, from brain to pelvis. Ultrasound is insufficient to cover all of these different vascular beds. Some other issues that I wanted to bring forward is that chest pain after SCAD is really common, more common than chest pain after atherosclerotic MI. And these patients tend to have high rates of emergency department and inpatient chest pain evaluations. I think it's also important that the chest pain they experience is not always ischemia. Sometimes it's chest wall. Sometimes it may be related to the dissection itself. Also need to consider restenosis or stent issues. And finally, some will have new or recurrent SCAD. So they need a comprehensive evaluation. The other aspect is that many of these premenopausal individuals have menstrual cycle variation in their chest pain, which many cardiologists are not familiar with. So we recommend an individualized approach, recognizing that there's an iatrogenic risk from repeat coronary angiography that must be balanced with the importance of a proper diagnosis. So stress testing can be helpful to exclude fixed obstructive lesions like stent stenosis. The coronary CTA can assess the proximal coronaries, which may be all we really need to do in terms of risk stratification. Sometimes empiric nitrate use is very helpful and is almost a poor man's diagnostic test for possible coronary vasospasm. So these individuals have clear nitrate-responsive chest pain but may pass a stress test and do very well on either long-acting nitrates or calcium channel blockers. And obviously, if symptoms persist, coronary angiography should be performed. Other things to consider, obviously, FMD and its associated conditions and complications that may require treatment. There's a significant psychological burden of having SCAD. We've known for decades that the highest risk group for developing depression after a myocardial infarction are women under the age of 60, which tends to be this demographic. So addressing those issues is important, often with cardiac rehabilitation. Women experience losses, particularly reproductive options, because we recommend that they don't get pregnant after SCAD, and at least for a year, just like for any other myocardial infarction. Recurrent SCAD risk is present even if the initial SCAD was not pregnancy related. So we recommend using an effective, i.e. not a simple barrier method, contraception, non-hormonal, and the levonorgestrel IUD is particularly attractive, particularly if individuals have menorrhagia because it decreases menstrual blood flow. Uterine bleeding is relatively common, particularly in those individuals who we've had to stop their oral contraceptives or who we put on dual antiplatelet therapy. And again, that levonorgestrel IUD or uterine ablation can be very helpful. And again, this is something that's not always on cardiologist radar. And importantly, cardiac rehab referral. This is important because I have heard from many SCAD patients that their cardiologist said, oh, you don't need cardiac rehab because you were already fit before that. And I think importantly, because of some of the mental health benefits of cardiac rehabilitation are important. So after SCAD, we start cardiac rehab 1 or 2 weeks after the event. If they have a large infarct or a very proximal dissection that is treated conservatively, may wait a little longer. We recommend avoiding high-intensity competitive sports, endurance and exercise to exhaustion, high-intensity activity, particularly in extremes of temperature. And we do recommend strength training long-term, but using lower resistance and higher reps. and limit lifting, whether it's in the gym, the home, or in the yard, to items that require straining or Valsalva. So we don't give a definite weight limit because that's very individual. We aim for a normal or lowish blood pressure and consider medical genetics referral, although only about 4 or 5% of SCAD patients have identifiable monogenetic mutation, and providing support for the patient and the family. I wanted to talk just a little bit about our prospective registry because we are still enrolling. We have over 1,400 individuals in our registry. It's a virtual registry, so individuals do not have to come to Mayo to be in the registry. They'd have to have an angiographically confirmed SCAD. We send questionnaires and ask for a personal SCAD narrative. We do have some prospective aspects, particularly for individuals who come to the SCAD clinic. So we have looking at echo and other radiographic aspects, and hopefully some prospective clinical trials. So to summarize, we will, if you're not already, see more SCAD because of increased awareness and intravascular imaging. We must have an index of suspicion for young women who don't have cardiovascular risk, who have the symptoms, and making a correct diagnosis, differentiating from atherosclerosis or spasm, is even more important because the management is different. The burden of recurrence is high, as well as the morbidity and associated with it. There's a strong association with systemic arteriopathies, and therefore screening should be done at least one time. Aim for a normal blood pressure, often using a beta blocker as a preferred agent. And referrals are welcome to both the Mayo Clinic SCAD registry and to our Mayo Clinic SCAD clinic. So I welcome you to learn more about SCAD as an important cause of myocardial infarction, particularly among younger women, that we have a lot yet to learn about. Thank you very much.
Okay, so thank you for that, for paying attention. It was a lot to take in. I definitely know that, and I saw some questions coming up that we can start taking. So I would invite my Mayo Clinic colleagues to unmute and turn your video on. I did want everybody to sort of introduce themselves and maybe just talking about some of the impressions or things that really over the past year since we've been in front of you, either highlights from a clinical standpoint or a research standpoint. So I'm going to start with you, Dr. Best.
So my name's Patty Best. I'm an interventional cardiologist. I think the things that, I have always been really interested in SCAD has been a lot of the pregnancy work, and we've looked a lot at the pregnancy in part because when you're looking at a very young woman and you're saying to them, you shouldn't ever get pregnant if they've never had kids, or you shouldn't have another child, it is such a huge deal. And I so appreciate that. And for me, that was always one of those very clinical things of importance. And then from patient standpoints, I think the other thing is that some of the anxiety that you were talking about, Sharon, with it's really because people feel that there's nothing they can do about it, which is true, but that like if you say you need to diet, you need to exercise, you need to stop doing something, people feel like they have a task and therefore they're in control of it. And it's kind of, you have to get people into a mindset where they're ready to handle that sometimes diseases will come and go as they please, and there isn't as much you can do about it as you wish you could.
Yeah, and I do think now we do have some more things we can tell. I tell patients they should have a normal blood pressure throughout their lifetime because I think there's some evidence that might benefit.
Yep.
So, and I also think I think what you meant was compared to atherosclerosis, there aren't as many things to do, but there are definitely things that we can do about anxiety, right? There's treatments, both medication and everything. So,
yeah.
Dr. Mankad, you want to chime in?
Hi, everybody. So it's great to be here. I've actually not ever done a SCAD walk. I've been meaning to, but never have gotten the chance. I don't specifically take care of SCAD patients, although with how overwhelming the schedule can be, sometimes I've pitched in, helped out. So I've learned a lot with what I've from Dr. Hayes, Dr. Tweet, Dr. Best, etc., about the condition. So I continue to learn through all of this as well. And what I keep we've done so much, right? We've learned about the issues related to the symptoms around menses, around your periods, the fluctuations with hormones, the link between maybe fertility treatment and all these different hormone things. Somebody asked about why is emotional stress involved? I mean, these are great questions, but we do see patients with SCAD present after something really exertional, and emotional stress is emotional exertion. So there's a flood of catecholamines, and your body goes into this fight or flight response. And that seems to play a role in this. So there's a lot we don't know. And that's what I've actually learned when I see SCAD patients, that I say a lot of times, well, we don't really know, which is why having all of you here and those who are participating in the registry and the research, it's so important, because all of you that are here, we know about SCAD because you already had the event. What I would love that all of this leads to is that we can figure out who it is that might be at risk for SCAD, so you never have the SCAD event to begin with, right? Because now we're taking care of all of you after you've had an event. Wouldn't it be great if we figured out who that was at risk? What does that makeup look like of the person who might have this event, and prevent events from actually happening up front? So that's what I'm excited about. And it's so exciting to work with Dr. Hayes and Dr. Tweet, Galati, and Best to see all that they're doing so that we can get to that next step. And we do that by collecting all of this information from those of you that have had these events, and kind of see how the disease is really playing out. So that's what I have.
Thank you, Dr. Mankad. Dr. Tweet, you still on?
I'm still on, yes.
Yeah.
So
I know you have a date with a bunch of children, and so we've only got you for a little while, so I want to make sure you have an opportunity to share your excitement about this.
Yes, they're patiently waiting for bedtime, and the dog is already asleep at my feet here. But I'm a cardiac imager. I've worked with Dr. Hayes since pretty much the beginning. Dr. Hayes kindly invited me when I was an internal medicine resident, and very naive at the time, thinking that this would be done in a year and I'd move on with life. And instead it's become a gigantic component of my career, but also my life. I mean, I can't imagine not doing anything else. A lot of what takes my mental energy, to be honest, is the big picture and sustainability of the research. Even just thinking about funding, I can't emphasize enough how much SCAD Research Inc. and the funding that's been provided has helped not only fund the research, but accelerate the timeline, because research is expensive and it doesn't happen by accident. You have to be incredibly intentional. And during that process, I've spent a lot of my own time not only trying to do research, but find funding sources. So as Dr. Hayes had mentioned, actually I've finished a 3-year NIH grant. It was a Birch grant to K-12. We did obtain Mayo Clinic departmental funding, which helped us conduct a echo SCAD focused study, which has been presented in abstract form, and the manuscripts are pending. And I recently heard about grant funding becoming available for an application that I submitted with a K-23 in collaboration with other colleagues at Mayo Clinic to better understand underlying mechanisms of the neurovascular interplay among patients who have SCAD. And the big picture is there's lots of different things that we absolutely need to look at. And along the way, we've answered a lot of questions, and a lot of what Dr. Hayes has presented is based on the research because of the SCAD registry participants, period. And the goal is, there's still many questions, as you all know. And in my mind, SCAD recurrence is always a big one. But how to answer those questions headed forward. And even when it comes to the genetics piece, we know so much more about SCAD genetics now than we did 5 or 10 years ago. So there's a long ways to go, because part of that is also disseminating the information to other healthcare providers, to other patients, to support each other. We also all invest a lot of time educating, because Mayo Clinic teaches medical students, residents, fellows, and continuing to work on teaching those individuals so that when they go to their location of practice, they're able to properly diagnose and treat SCAD, and maybe even take the lead on research of their own. So there's a lot of work to be done, but I have to say there's a lot of work that has been done already, thanks to your participation and your support, both financially and just in general. So thank you.
Thank you, Dr. Tweet. Kari, I would love for you to chime in, because people probably don't know you, but you're an important person in our SCAD clinic practice.
Hi, I'm Kari. I'm the nurse practitioner in the Women's Heart Clinic. I've been in the clinic for over 12 years. And I'm kind of an in the background person. What happens when someone is scheduled for a SCAD visit, I go through all the chart and the information that is sent in from their local providers, and make sure we have all the right information, kind of put together a brief synopsis of what happened, make sure that we aren't duplicating orders when a person comes to Mayo Clinic. So I go through a lot of charts, and I have to say about a month ago, we had 16 new SCADs in 2 weeks. And I got to tell you, I was really busy, and I had to pause about that a minute. First of all, it's kind of upsetting that 16 new people needed to be seen for SCAD. But on the other hand, we had 16 people who we were going to see, try to maybe better educate, make sure their medications are right, and they get to be part of the process of helping us understand how we can better treat. And so it's kind of a double-edged sword. And I think a lot of this right now is a double-edged sword. Yes, all of you have experienced a SCAD when we don't know a lot about it. But as each one of you is willing to share your information, we're going to better be able to care for those that come after you with their event. And it's probably not a great place for you to be individually, but for the greater good, we so appreciate every one of you allowing your records to become part of our process.
Thank you, Kari. So I'm going to take a few high-level summary questions because there have been some themes, and I'll toss them to some of my colleagues, but some are logistical. So I'll just start with those. Can you be seen at Mayo Clinic virtually in the SCAD clinic? The answer is until the end of the year, probably, although I think we're pretty much booked out. The reason we could see virtual patients was because of the emergency order for the pandemic, and they are probably going to go back to the old rules. And the old rules meant that we could see you as a virtual visit. And for those of you, many of you probably had one, but you had to have had an in-person visit once. You had to actually officially been our patient. We are hoping that, I mean, this is not just for us, this is for pediatrics and for everything, that there will be some semblance of virtual medicine available after the pandemic. But as of now, we're being advised we're probably going back to the old rules as early as January 1st. Stay tuned, because we have during this past 2 years seen lots of virtual visits. Another question, if you're in another registry, you can be in our registry. Each of our registries, you know, we work very closely. If you look at what we've co-authored with the folks from Australia, from the folks from Vanderbilt, from Vancouver, and we are all focusing, although we may be focusing on SCAD, some are focusing on imaging or genetics. And so there is some benefit to the science to be in more than one if you're willing, but it's obviously extra work for you. But it doesn't, and I see somebody, I'm joining the Australian research with the Victor Chang research in Sydney. And so, yes, we have collaborated, and particularly on some of the DNA, because they have a nice DNA biobank. Oh, and Kari just sent me the emergency order got extended. She's in the know because she's in the to April. So I guess we got till April to look for a first-time video visit. So anyway, those are just logistical questions. And if you have others, we're always happy to respond to those. We have a great appointment coordination team and a clinical team, as well as the research team, and we all work very closely together. I think that the video did focus a lot on women, which is what I had been asked to put together by my department. But I think it's important to know that if we think we do not know enough about SCAD generally, we know even less about SCAD occurring in men. It probably occurs of all SCADs, probably about somewhere between 5 to 10% occur in men. And we have less than 5% men in our registry. So what that means is we're probably under enrolling for men. We should have more than we do. And I think that if you know of men who experience it, obviously men who have SCAD probably have something different. They don't have the hormones. It is much less common. And so enrolling men in our research and other research, it will be really important for that. Most of the advice that we give in terms of exercise and other things are very similar to that. One thing that has been shown, it does appear that men who have SCAD are more likely than women to have it during extreme physical exertion. I'm gonna put a question out because there's a couple on medication, and I might toss this one to Dr. Best. There's a couple of questions that said, medications, beta blockers, are they good? Do you have to be on them? Are calcium channels blockers just as good? And maybe just start with why beta blockers are thought to be.
Yeah, thank you. I was trying to start to answer things in the chat, and I can't type all that fast. So there has been retrospective data that suggests that in people who are placed on beta blockers, they have a lower risk of recurrence. And
You're good.
I'm good. Okay. And because of that, it appears that it is a useful medication for preventing recurrence. We don't have prospective randomized data, as we don't really have any prospective randomized data for much within SCAD, just because of the state of where we are with the research. There has not been the same findings in retrospective data about calcium channel blockers. That does not yet mean that that is not possible, that it can be beneficial. It just means that there's even less evidence that that would be beneficial. So someone who cannot take a beta blocker and their blood pressure is elevated, there's a couple of good choices based on some logical answers, but not as much based on SCAD. And so things like ACE inhibitors or angiotensin receptor blockers, because they have been shown to be beneficial in people who have other collagen vascular disorders that can lead to larger blood vessel dissections, that would be a reasonable thing to consider. And so the calcium channel blockers, just there isn't enough information, and there haven't been a lot of hints at it from the data that we have. And so that probably wouldn't be my first choice.
Yeah. So, and I think Dr. Best too, I want to emphasize that it is a single observation about the beta blockers.
Correct.
That doesn't mean it's not true, but it has not. So I think what
we haven't seen it elsewhere. Yeah.
Right. And I think that's what that tells us is I have heard that some patients have been told, even though you feel lousy on the beta blocker, you must stay on it. And I think the data is not such, quality of life must figure in. And that is so it's not an absolute. I personally like to see people on a beta blocker at least that first year, but if they're really not tolerating it well, we stop it. Dr. Tweet, do you have anything to add to that? It's the conversation about high blood pressure and beta blockers.
I agree. I mean, I think that's what we have to work with. So that's what we use to guide us. And the goal of continuing to do research is to better answer that question.
Yeah. And I think the other part is, I do think that control of elevated blood pressure makes sense, as well as people with hypertension have, in that same observational study, shown to have more recurrences. And that makes sense, right? Because the most stress that goes on our arteries is the force of each pulse of blood pressure. And so blood pressure tends to rise over the lifetime. In men, kind of gradually as they age. In women, they have lower blood pressure than men. And then around the age of 60 or so, even people with women with low blood pressure, it may go up. And so that's why we tell women, and if you've seen me, I emphasize, you may have low blood pressure now, but make sure in 20 years you still have low blood pressure, and we'll have better options at that time. Another question kind of had some themes, a little bit about specific drugs. One of them, the question about Imitrex, and Dr. Tweet, since you were involved in the migraine study, if you want to just talk about what you have learned about that and what are recommendations regarding the triptans.
Correct. So there's in particular a lot of anecdotal concern about Imitrex and other triptans, so other medications in the same family, primarily because their mechanism of action to stop the migraine is to cause the vessel to spasm down. And the concern is that could also contribute to spasm of the coronary artery to the heart. And in a patient who may be already vulnerable to SCAD, that would not be considered a good thing. And there are anecdotes out there of patients taking either high doses of triptans, such as Imitrex, or a large amount, say several doses quite in a row, right before the onset of their symptoms related to SCAD. So currently we try to recommend alternative medications to take for both migraine prevention as well as rescue. A lot of people like the triptans, so it can become a challenge. Beta blockers in of themselves for people with migraines can often help prevent migraines. I did notice in the chat, someone asked about beta blockers in chest pain. The beta blockers can help with angina, except if you do have coronary spasm, sometimes that can make those symptoms worse. So you come down to individual discussion. And then when it comes to the migraines, for example, you start exploring other options. I've had some patients even go to the extent of Botox therapy for refractory migraines, along with some other things. Sometimes we need to get neurology input, but those are my thoughts.
I'm going to take, because there's several questions about fibromuscular dysplasia, and one question is it important to be tested for FMD because there's no treatment for it? I think I want you all to walk away from this is the CT angiogram from here to there, here to, brain to pelvis, is not to rule out FMD. You may have been told that it's a shortcut that your doctors, that is not the reason that we do it. We do it to identify if there's an aneurysm or a dissection or something that needs follow-up or treatment. FMD can be very subtle, and the non-invasive tests that we use are imperfect. So even if a patient has a clean scan at Mayo Clinic with our great radiologists, I don't tell them, oh, great, you do not have FMD, because we know that maybe the FMD is manifest in the arms and legs where we don't image, or maybe it was so subtle that we couldn't. So I think it's really important that you understand that what we're looking for is make sure you don't have a brain aneurysm or a dissection somewhere else that we would want to make sure we took care of. It's a common misconception that the only reason to have a scan is FMD or not. And I think so we do recommend it. It is generally now covered by insurance company as well. So I think that we don't want, if you've had one dissection, to have another dissection or aneurysm somewhere else. FMD you may have, but it probably won't change the treatment other than us being making it even more important that you have normal blood pressure. And remember, normal blood pressure is less than 120/80. Hypertension is greater than 140/90. But when I say we want you to have a normal blood pressure over a lifetime, that doesn't mean just treating high blood pressure. It means trying to get it at normal. Another question, the group of questions was a little bit about emotional stress and how it plays in, and takotsubo. For those of you who don't know what takotsubo is, it's also called stress cardiomyopathy. It tends to happen in older women, postmenopausal women, but also is associated with emotional stress. So we think that there may be some link there. Do Dr. Best or Tweet or Mankad, do you want to weigh in just about We think it's because of this. When you're really stressed, you put out a lot of stress hormones, which may affect the small blood vessels and larger ones. But anybody else want to comment on?
So takotsubo's has some overlap and similarities with SCAD, and amongst them includes the fact that it has a much higher predilection for women, and so women are primarily involved, and some of the stressors that are seen with it. In one of the chats, someone asked if they could be confused whether or not it's SCAD or whether or not it's takotsubo's. The answer is yes. And how you rule out that takotsubo's is a coronary event is by doing an angiogram or some sort of other imaging to make sure that there isn't something else going on. And I've seen where someone thought off of the echo that someone was going to have takotsubo's and they turned out to have multivessel SCAD. So that definitely can occur. The stressors and emotional stressors, there's a long list of things that we see clinically in patients of, I can remember someone's, it was the day of the funeral of their daughter. I'm like, okay, that's an overwhelming stress that I can't even imagine. I've heard lots of deaths of pets. I've heard lots of, issues with caring for parents who are having health issues. And so that we certainly see that emotional component, and that's certainly been known in takotsubo's. And for some reason, women seem to manifest more related to their heart and than men related to these emotional stressors. So I do think that we're going to end up finding that there's an overlap between the two, and it's probably based on women having a similar reaction in the appropriate patient.
Thank you very much. I think that there's several questions about medications, and one is about aspirin and Plavix in general, and because of some of the newer, it wasn't actually new, but the recommendation of even walking farther back, the use of aspirin for preventing a heart attack. One way I like to frame this is that SCAD is a bleeding event. If you think about it, it is, it's a tear. It may be a bleed between two layers of the arteries, whereas atherosclerosis, the regular type of heart attack, that's a clotting event. And so we use aspirin, we use Plavix, we use heparin, all types of different blood thinners, some very powerful, because they've been shown to melt that clot and open an artery. Whereas in SCAD, there really isn't much evidence of clot. In fact, in angiographic studies, if we see clot, we look again and say it probably isn't SCAD. So one thing is, we don't use dual antiplatelet therapy, meaning like Plavix plus aspirin early on if you don't get a stent. You need that for a stent. There was a study that was just published in the European Heart Journal, for which I had the opportunity to write an editorial. It was not a randomized trial, but they found that people with SCAD who had dual antiplatelet therapy, so Plavix plus aspirin, versus those who were on aspirin alone, had more bleeding and more early complications related to extension of their SCAD. So we really don't recommend dual antiplatelet therapy for SCAD, and some people are still getting it prescribed for a full year. And I think we have to question the aspirin. I'm certainly telling people they can stop the aspirin at some point, certainly if they're having a lot of bleeding. And I think there's no evidence we benefit SCAD patients with aspirin beyond a few months. And so it's in flux, but I'd love to hear from Dr. Best and tweet your practice. I just, even in the past year or two, have sort of backed off on aspirin generally.
I basically concur with you. For the utilization of aspirin, there's never been any strong evidence of utilizing aspirin. And so I tell every patient that a lot of the groups have recommended doing this, but there's really no evidence behind it. And so I'm pretty neutral on whether or not someone stays on aspirin.
So I'll add, because I saw a question in the chat just come across. For patients with stents, we do the dual antiplatelet therapy typically for 1 year following the MI. There are always unique circumstances where you reconsider. In regards to conservatively managed SCAD, so patients who have had a SCAD but no stents placed, I do tend to drop one or the other quickly so that they're only on a single agent such as aspirin or Plavix. And then in terms of how long to continue it, I've been continuing it in patients. I take into account things like, is there fibromuscular dysplasia elsewhere? Is there maybe concurrent atherosclerosis? And I think with time, these recommendations will change or be adjusted based on what data is coming out. But in general, that's my practice. And then I, always take into account any side effects someone is experiencing, because again, it always comes back to what's the risk and benefit ratio for this individual.
Yeah. So in general, after a SCAD with no stent, they don't do anything. The use of aspirin for a short period of time may be reasonable, not mandatory, and certainly none of us are in favor of putting somebody like that on both drugs because there's no evidence and it may cause harm. There were a few questions, and if we had Dr. Olson here, there were a few questions just asking about genetics. There have been reported rare cases of familial SCAD and rare cases of familial fibromuscular dysplasia. So it is not common. We have about 12, 14 families out of the 1,500 or so that we have in our registry. In those that we have looked at as a family, though, there is no single SCAD gene or FMD gene. I mean, we know that. We've done enough genetic testing to know that. But what has come to light is what we call susceptibility mutations. And that is where on certain genes, there may be a mutation that makes it more or less likely that you have a SCAD or more or less likely that you have fibromuscular dysplasia. Doesn't mean you absolutely get it. And so that is still very much in the research realm. These are not diagnostic tests you should go and ask your doctor to get, but maybe something that there may be a panel of those that we can help risk stratify at some point in the future. And that was one of the big papers that we collaborated with Mount Sinai and Leicester, University of Leicester in England, and the Victor Chang Institute to try to really and that's what it's going to take, is all the big registries coming together. Dr. Tweet, did you want to add anything? I know you worked really closely on that.
Yes, I think the hope is that, granted, if there was a single gene mutation for SCAD, it would have been discovered by now, and or FMD. So we're headed more in the direction of polygenetic risk scores, similar to what exists for atherosclerosis. Where it can give it a level of risk. And we've got a ways to go, in my opinion, but actually found a lot along the way. And the advantage of the genetic work, in addition to maybe assessing risk or informing families, is also trying to understand mechanisms and why SCAD occurs to begin with, and really how do we develop animal models, or kind of the next step of investigation to then further develop therapies.
Thank you. I think there's several questions about hormones, perimenopausal, and pregnancy, and I think maybe just having a little conversation about that. So in general, if somebody doesn't feel strongly about having another pregnancy after having a SCAD, we advise against it, just because it is a higher risk period of time. But we realize many people need or want to get pregnant. They also, and not all birth control works. So I think having a plan if pregnancy happens, and knowing that unlike some of the other cardiac conditions for which people get pregnant with, heart failure or a valve problem or something, those are things that you know in advance that they have. We treat along the way, we watch for certain things. And one of the challenges is the S is spontaneous. It isn't something that we can plan or anticipate. And so if you're thinking about getting pregnant, we want you to be in the best health you can. You have to have good preconception planning about the medications that you're taking, and then close follow-up. But I think that it really have to, there's so many factors, and we are not here to give advice other than to say that people do get pregnant and have had successful, healthy pregnancies after SCAD, but some have not. And then I'm going to let the other two weigh in, because the other thing was around menopausal hormones. Similarly, menopause is a time of dropping hormones and evening out. Even with the hot flashes, it's not really because of the fluxes in hormones. And although we'd like to avoid systemic hormones in patients after SCAD, because we just don't like to add another variability, if somebody is having a quality of life issue and non-hormonal treatments have not worked, we have lots of patients on SCAD who are taking it. We like to work with our menopausal medicine, but don't let some cardiologist tell you you absolutely cannot go on a postmenopausal estrogen patch. I mean, I saw Dr. Best nodding, because there's not good evidence, right?
With the issues with hormones in the postmenopausal woman, I've had more people who I've helped them stay on hormones or get on hormones because of quality of life. And you just have to talk about the risk benefits. And honestly, a lot of with SCAD, we just don't know enough to know that. I don't know that the risk is very high with it. I would think if it was a very high risk, we would already know that.
I think one of the things that is reassuring is if we think about what the average age is for SCAD, it is in the 42 to 52. There's not another bump after, around 50. And I think that is when menopause typically is. There are a lot of questions in the chat that are very specific to your own case, and we unfortunately cannot answer those questions for you, like how long you should be on a medication, because we obviously do not know all of your medical history. But if the talk or anything, or this conversation raised any questions for you, I think do talk to your local cardiologist who's caring for you, because things have evolved and changed. There are things I'm telling SCAD patients to do or not do today that I was not telling them 8 years ago. And so I think that's where we all need to stay on top of the science and adjust and adapt. We're getting very close to, I think, when everyone wanted to, we've got lots of questions we haven't answered, but also to the breakout, and we can take some of those questions during the breakout that you have about this. I would just say that I thank you all for being a part of this. And Dr. Tweet has her hand raised.
I just, can you hear me? Yes. I was just looking at the chats, and I do think that with the antiplatelets, there's still some confusion in maybe how we explain things, because I think people are confused about the dose of aspirin we're talking about, but also Plavix versus aspirin. So Dr. Hayes, do you want to maybe clarify that a little further before we go into the breakouts? Because I think that's an important point. And I will say, for a large portion, and even still in my practice, I commonly keep patients on a baby aspirin alone, but frequently take them off the dual antiplatelet therapy shortly after conservative management for SCAD. And really, this is very much a data-free zone, but I saw a lot of confusion. And when we say baby aspirin, that's the 81 milligrams of aspirin, not a full dose aspirin.
So for a regular heart attack, if you had a heart attack due to atherosclerosis, we would tell you to go on aspirin and Plavix, or one of these, so dual antiplatelet therapy for a year, whether you got a stent or not, okay? So that's that. And so the question is, should we be treating SCAD patients the same? And it is our opinion that we should not, that the aspirin may be reasonable and continuing it. And again, I think there's some uncertainty and some change, but we would not continue long-term or a full year of the dual antiplatelet therapy. And so, and in general, unless you have a problem, allergy, or something else to aspirin, the single antiplatelet therapy is generally aspirin alone. People who have an aspirin allergy, they may be put on the Plavix or the clopidogrel.
And then the exception to that would be if someone had stents, then that changes it.
Yep. Right. And then I guess because somebody said SCAD sounds better than some heart attacks as outlook, I will emphasize that SCAD heart attacks, there are exceptions, but on average, they tend to be small. They often happen in the distal vessels, so there's not a lot of heart muscle or less heart muscle that's involved, and they are and survivability is higher than an average heart attack, in part because they tend to be healthier. So with that, I'm going to hand things back to Ellen, I guess.
Yeah, thank you, Dr. Hayes. That was great. And thank you to everybody from the Mayo Clinic.